Okay. Great.
Sorry about that.
Are we good? Yeah. Okay, so I'll just do a brief intro.
Yeah.
All right. Hello, everyone. Welcome to the Illuminate series. Today we have Ms. Jill Sutherland, who is with she's the Manitoba Liaison Officer for CADTH, which is the Canadian Agency for Drugs and Technology in Health. Her clinical background is radiation therapy, and she holds a master's degree in health studies. Jill has spent many years working clinically and also has experience in education, professional development, primary care, and program management. She's been active in research and has interest in supporting evidence-informed decision-making. So if you don't know CADTH, CADTH is an independent, not-for-profit organization responsible for providing healthcare decision-makers with objective evidence to help make informed decisions. And she's going to talk today about how some of us may actually be able to use CADTH and work with CADTH. So welcome, Jill.
Thank you. Thank you very much. Is everyone here okay? Perfect. So thanks for inviting me to speak today. It's a real pleasure to be here today. As Dr. Urbanowski mentioned, I am the Manitoba Liaison Officer for CADTH, and my clinical background is radiation therapy, which is often referred to as RT, so it's not infrequently confused with respiratory therapy, but that is not my background, so I will not profess to be an expert for any of the respiratory therapists in the room. I am based in Winnipeg. I work remotely from home, but I do cover the province, so I understand that there are a number of individuals joining us via live stream from across the province. So I would just note for those of you who are tuning in via live stream that I'm always happy to come out and meet with you in person in your own communities, wherever you might be located. So transparency is a priority for CADTH, so just a couple of disclosure slides. CADTH is funded by federal, provincial, and territorial ministries of health, and we receive application fees for 3 of our programs, and I'll be speaking to those programs in more detail in the following slides. I have no personal disclosures today. So CADTH is an independent, not-for-profit organization that is funded by Health Canada, provincial ministries and territorial ministries of health. And I was asked to provide an overview of CADTH, and so that we might have a discussion about how CADTH might be able to support the work that you do. So it would be helpful for me to get a sense of whether or not you are familiar with CADTH, if you've accessed our resources or reports before. So just for those in the room, show of hands, if any of you are familiar with CADTH. Okay, so most in the room are. That's nice. Sometimes I speak to audiences and it's the first time that they've heard of us, so CADTH is not an acronym that they're familiar with, but Canadian Agency for Drugs and Technology in Health is sometimes what people have heard of us for. So really our mandate is to conduct evidence review so that we can support decision makers at all levels of the healthcare system. So within Manitoba, I interact and connect with Manitoba Health, Shared Health, Regional Health Authority, leadership teams, provincial councils and working groups, as well as individual physicians, clinicians, nurses, pharmacists. And I'm hoping that after today, having the opportunity to speak to those of you in the College of Med Rehab, that we might be able to identify opportunities in areas where we can also work together. And I'll also mention that I am the Manitoba Liaison Officer based here, but at the national level, we also have a liaison officer who provides support to federal programs like Veterans Affairs, Corrections Services, the RCMP, the Department of National Defence, Indigenous Services, as well as Health Canada. So CADTH was established in 1989 by Canada's federal, provincial, and territorial ministries of health, and we were tasked with coordinating a pan-Canadian approach to health technology assessment. So our organization has about 200 staff, the majority of which are situated in our head office in Ottawa, and we also have an office in Toronto. And we also have a number of advisory and expert review committees whose membership are from the healthcare system, and they represent jurisdictions from across the country. And we also work very closely with public and patient members. So in addition to evidence analysis, CADTH also provides recommendations around the evidence. We provide recommendations about the optimal use of health technologies. We do a lot in the area of knowledge mobilization tools because we really want to support the implementation, uptake, and use of evidence. So Why customers in healthcare with a healthcare background? Typically, we refer to those that we are serving as patients or clients. But CADTH uses customers because we are here to support you, those of you who are working in the healthcare system. And because we are funded by Health Canada and Manitoba Health, we do have a defined subset of customers who are eligible to request CADTH to undertake work on their behalf or consult with me. But I want to be clear that we are not a fee-for-service organization, so there isn't any cost to using our reports or for consulting with me. Our defined sort of customer user base is the government, Manitoba Health, and related departments, regional health authorities, health facilities like Health Science Centre, Deer Lodge, Brandon Regional Health Centre, and other service delivery organizations like Cancer Care Manitoba, Addictions Foundation Manitoba, CADTH Provincial Lab. So organizations that we typically do not consider to be our customers would be physicians or other healthcare professionals who are working in private practice or fee-for-service models, as well as universities, academic institutions, students, and researchers. So I hope I haven't alienated anyone in the room by saying that, but as we'll talk and get through the presentation, I think we will identify opportunities where you'll see where CADTH can be a resource and support to you. Also, provincial or national associations like the College of Family Physicians or Diabetes Canada, the Canadian Lung Association are not organizations who we actively do work for, as well as the media or patients or public. Any questions at all about our customer base? Okay, I just want to be transparent about that as we move forward. So one of my objectives for today is to provide you with a better understanding of what CADTH is, but also hoping to hear from you about your clinical topics, priority topics that are happening in med rehab right now, and discuss how CADTH could potentially contribute to and support your work. So before we do that, I just want to provide a few definitions and some background that may help to facilitate that conversation. So CADTH, like healthcare in general, has lots of acronyms. We can be acronym heavy, so please interrupt me if I slip into acronym mode or forget to define an acronym. So health technologies, as defined by CADTH, are any interventions that are directly involved in patient care with a purpose to achieve a specific outcome for that patient. So it can be used for diagnosis, treatment, mitigation, or prevention of symptoms or diseases. So when we're determining whether or not a medical device or an intervention is a health technology, we consider the purpose of the intervention. So what does the technology aim to achieve? And in general, if the immediate purpose is to treat, mitigate, diagnose, or alleviate symptoms of a disease, then it is a health technology. So this includes pharmaceuticals, which also includes blood products, vaccines, prescription and non-prescription medications. It includes all medical, dental, and surgical devices, all medical, surgical, and dental procedures, and diagnostics like lab tests, blood values, cancer screening programs, diagnostic imaging, so CT, X-ray, ultrasound, MRI, all fall within scope for us. And I think it's also important to note that health technology includes clinical interventions like cognitive behavioral therapy or internet-based cognitive behavioral therapy, the use of telehealth, so it really is a very broad scope. So my key message is if you have a question as to whether or not it's a health technology that CADTH could evaluate, please be in touch with me and we can discuss whether or not it's in scope or not. Things that are generally considered out of scope would be things like overall health system design, program delivery models, and operational budgets for health service organizations. I have a question.
Yeah, so medical, dental, and surgical, are you using medical broadly? Like would rehab fit in that or not?
It is, absolutely. And I have some examples of reports that we've done just to really give you a sense of the scope of topics that we do cover. Yeah, so if we think about health technologies, to treat a condition like chronic pain, there are various technologies that might come into play for a patient. So on the pharmaceutical side, it may be Nablone, which is a drug that can be used for pain management. On the medical device side, it could be something like a TENS unit or a mattress for chronic back pain. So we'll look at whether or not certain mattresses are helpful in alleviating chronic back pain. And then as far as treatment goes, physical treatments, so physical therapy, occupational therapy, all of that falls within scope for us. So I wanted to touch briefly on optimal use. which when CADTH is talking about optimal use, it's really about obtaining the greatest benefit and outcomes possible from the resources that we've invested. So our annual healthcare costs are approximately, does anyone know? So over $240 billion a year in Canada, and that represents about 37% of provincial and territorial budgets. So it is not an insignificant figure. But the key point around all of that is that, you know, we can spend these huge sums of money on technologies that do not improve quality of life, may be harmful, or we can invest those wisely by identifying those technologies which are going to achieve the greatest impact and outcomes for patients. So quality experts estimate that as much as 30% of healthcare is useless or even potentially harmful. And adverse drug reactions kill thousands of people every year. Physicians, through the Choosing Wisely campaign, have identified hundreds of tests and interventions that are not optimal use. Is everyone familiar with Choosing Wisely? Okay, so you may be familiar with their More is Not Always Better campaign, and certainly with respect to rehabilitation sciences, they have issued some recommendations, and their recommendations are developed by clinicians and are evidence-based. So optimal use is really about how, when, and where to use technologies, where we can identify that the benefits exceed the health risks. It's determining which settings or which specific patient populations in which a new technology might provide clinical effectiveness or cost effectiveness advantages over other technologies. And on the flip side of that, it's just as much about not using technologies where there isn't evidence of benefit and avoiding unnecessary care. So CADTH does a lot of technology assessment to help inform the adoption of new technologies, but there also is value and merit in reassessment. So when a new technology has been in practice for a period of time and new evidence may be generated around that technology, reassessment can be helpful just to assess whether or not we're still getting good value from it. So Canada certainly has a huge opportunity to get better value from healthcare, and CADTH has resources and expertise to help guide this. So an example of this is Docusate, which is a medication that is used for the prevention and management of constipation. So CADTH was asked to undertake some evidence review to look at the clinical effectiveness and cost effectiveness of Docusate. And at the end of the review, we found very little evidence to support the use of Docusate in hospitalized patients or in long-term care residents. It didn't increase stool frequency, it didn't improve the symptoms of constipation, and as a result of that, Docusate was removed from the formularies in 8 jurisdictions. So even though it's not an expensive drug, and many drugs are much, much more expensive than Docusate, from a health system perspective, it can never be clinically effective or it can never be cost effective for the system to prescribe a drug that is not clinically effective. So what is optimal and how do we determine what is optimal? So CADTH, one of our catch lines is, what does the evidence say? So we try and approach this from an evidence-informed decision-making lens, which really is sort of a progression from what formerly was known as evidence-based decision-making. Evidence-informed decision-making reflects a more thoughtful approach to, what is the best scientific evidence available, and how does that evidence fit with the local environment, the clinical experience for particular decision-making situations. So evidence is a component of the decision-making process, and using evidence to inform clinical practice or policy change initiatives also involves planning and support. So part of my role as liaison officer is also being available as a resource to help plan for using and implementing the evidence. So some of the challenges that decision makers face around using evidence are related to the amount of evidence that is available. It's related to critical appraisal and assessing what is the quality or credibility of the evidence that is available. Is it non-biased research? How do we interpret and use the results? Can we apply the results of a particular study to our local population in Manitoba? And one of the dilemmas that we see with evidence is that what sometimes can come into play is that you have an action that is not informed by evidence, or you may have evidence awareness that is not then followed by a related action. So closing the gap between evidence and policy and practice is one of CADTH's strategic goals, because we recognize that evidence can be received and understood, but it may not always be translated into action. So there's no shortage of evidence available. Staying abreast of current research is sometimes likened to drinking from a fire hydrant or a water hose. So health technology assessment really does aim to help clinical decision makers manage the volume of evidence that's available. So health technology assessment is a research approach. It's a systematic evaluation of a body of evidence that looks at the effects and impacts of a particular health technology. So there's rigor to the methodology. It's a multidisciplinary approach that involves research information specialists, clinical research associates, clinical experts, patients, public, health economists, a large team conducting this type of research. So health technology assessment is not about generating new evidence, so it's not conducting retrospective studies or randomized controlled trials. Really, it is about informing what the collective evidence says so that we can make decisions to ensure that we're getting the greatest benefits and outcomes possible from the money and resources that we're investing in the healthcare system. So most of you will probably be familiar with the standard hierarchy of evidence. One of my colleagues has taken a bit of artistic license and placed health technology assessment at the top of the pyramid. But generally, expert opinion case studies are considered to be the lowest quality of evidence, with different study designs moving progressively up the hierarchy. Systematic reviews and meta-analysis are generally considered to be the highest levels of quality, because they synthesize a body of evidence by taking a rigorous approach to not only finding the evidence available, but also critically appraising it. And then health technology assessment undertakes systematic review of the literature, but then builds on that by looking at different components. So what value does health technology assessment add? You know, with the plethora of evidence that is available, how does it differ and what value does it bring? So we know that health technologies drive a great deal of healthcare spending. So there's lots of disruptive technologies that are coming to market, like remote monitoring, mobile monitoring, artificial intelligence, robotics, 3D printing. These are all hot topics. And certainly they offer hope for breakthroughs in the ability to improve health, but they also create major demands for increased spending. So even if they prove to be genuinely effective, some of the new technologies, particularly new niche drugs for treating cancer and rare diseases and gene therapies, come with an enormous price tag. And so decision makers face a dilemma of deciding which innovations to implement, which innovations to buy, what price should be paid for these interventions, how many should be implemented, and how to foster appropriate use amongst clinicians. And if these decisions are not made from an evidence lens, there is concerns that the forces of innovation and marketing can drive the adoption of new technology. So, in addition to a systematic review of the literature, health technology assessment also includes several additional components. So there will be a review of the clinical effectiveness of the technology. There will be a review, an economic analysis that looks at the cost effectiveness of the technology, as well as implementation considerations, such as whether a drug or procedure or intervention should be available in every province or every site across the country. And it also considers patient and caregiver experience as well as clinician experience. So part of the process is gathering information from patients and caregivers about their experience using a particular drug or using a particular intervention, as well as clinicians who've had experience with that health technology. So when CADTH is looking at this from a health technology assessment lens, we frame research questions in a way that will support decision making. So we look at whether or not technology X offers a clinical advantage over the alternatives. Is it cost effective? Who would benefit from its use? And most of the time we try to make use of the PICO format when we're formulating our research or policy questions. So P being the population of interest, I being the intervention, C being the comparator, and O being the outcomes of interest. So at the end of the day, HTA answers questions like, is it safe For whom does it work and when? Is it better than what we already have? Can we afford to do it? If we invest in this new technology, do we need to disinvest in some other technology within the healthcare system in order to accommodate the increased spending? Is there a trade-off that needs to happen if we implement this new technology? So hopefully I've convinced you of the value of HTA. And now just to talk a little bit about how HTA can be used to support decision making. So on the public funding or reimbursement side, we make recommendations about whether or not drugs should be publicly funded through our provincial drug plan. Within Manitoba and across Canada, some of the most commonly purchased medical equipment are IV pumps, home dialysis equipment, scopes, defibrillators, and ventilators. So on their own are not necessarily, they don't carry a huge price tag, but when you look at the volume that is being purchased, it does contribute significantly to healthcare budgets. So health technology assessment can certainly help guide purchasing decisions. Mental health and addictions are a priority area in the province, so deciding which clinical interventions to invest in can be challenging. So health technology assessment can provide guidance as to the effectiveness of new technologies like telehealth or internet-based cognitive behavioral therapy for treatment of conditions like anxiety, depression, post-traumatic stress disorder. And for groups who are involved in creating clinical protocols or clinical guidelines, HTA offers a synthesized body of evidence for them to deliver over. So just sort of as an aside, how health technology assessment recommendations or health technology assessment differs from clinical practice guidelines. So health technology assessment is a consistent, rigorous, systematic methodology that is employed, whereas depending on the guideline group, they may use different methodologies to develop their clinical practice guidelines. And health technology assessment really is more about assessing the cost effectiveness or value for money, looking at things at a population level, whereas the clinical practice guidelines really are focused on a very specific patient with a particular condition, and it really is intended to guide a clinician's decision making around how to care for that individual patient. HTA is looking at it more at a system level. So before I talk a little bit more about CADTH and our products and services and how we might be able to work together, I just wanted to pause and see if there are any questions or feedback about what constitutes a health technology or the process that we use for health technology assessment.
Maybe you're going to get to this, but does the public have access to previous health technology assessments?
Yes. Yeah, absolutely. So all of our reports are publicly available on the website, on the CADTH website, and I will provide you with the link and direct you to that. Yeah, absolutely. So CADTH has a range of programs and services, so I'm sharing these with you not with the expectation that you'll remember all of them, but really just to provide you with a sense of the diversity of support and expertise that we have, and hopefully that will sort of maybe stimulate some ideas for how you could use CADTH in the work you do based on your specific needs. So we have 4 service areas. We look after drug reimbursement recommendations. We have a health technology management program, implementation support services, and scientific advice. Our scientific advice program is a program that provides consultation services and advice to pharmaceutical companies who are in the very early stages of their drug development plans, to give them some insight into health technology assessment processes and how health technology assessment is used in drug approvals, so that when they're designing their very early research studies, they're designing those with health technology assessment in mind, and with a lens as to what the approval process is, because some of the approval processes vary between countries. So CADTH is responsible for the Common Drug Review and the Pan-Canadian Oncology Drug Review. So for the Common Drug Review, we review 40 to 45 new drugs each year, and on the oncology side, we review around 20 to 25 new drugs each year. So Health Canada approves a drug. So when they look at a drug, they look at whether or not it's safe and whether or not it is effective, and then they will approve it. So the drug manufacturer will then submit a request to CADTH through the Common Drug Review to review the drug and make a recommendation as to whether or not it should be reimbursed and added to public drug plans. So CADTH reviews it with a lens from looking at the clinical effectiveness, the cost effectiveness, and patient perspectives before making or issuing that recommendation. And we look at comparing it to what other alternatives are currently available and whether this new drug adds value to the system. Once that has been done, there is a group, the Pan-Canadian Pharmaceutical Alliance, who negotiate on behalf of the provinces collectively to obtain better pricing. So the Pan-Canadian Pharmaceutical Alliance does have a website where you can search which drugs they are actively negotiating, those for which a negotiated price has been confirmed, and those which potentially are not being negotiated at a pan-Canadian level. So CADTH does some economic modeling. We look at the cost effectiveness, but at the end of the day, we do not have insight into what the final price is that drug plans are able to achieve for a particular drug. So once a drug manufacturer has submitted a request for CADTH to review their drug, there's a number of steps before a final recommendation is issued, but I'm not going to walk through them all. I just want to note that the first step is a call for patient input. So patient groups have opportunity to share what their experience may have been with using a particular drug if they had access to it through a clinical trial. And they also have opportunity to share what their experience is living with a certain condition or disease. And then CADTH review teams use that patient input when we're developing protocols. Our expert committees who deliberate on the evidence and make the final recommendations also take that patient input into consideration. And then finally, that input is shared with public drug plans and posted publicly on the CADTH website for anyone to review. So it is the Canadian Drug Expert Committee who issues recommendations as to whether or not a drug should be funded. There are 14 members of the committee, and that includes physicians, pharmacists, and public members. And they deliberate on a number of areas before they issue a recommendation, and then that recommendation is shared with public drug plans. At the end of the day, it is the Minister of Health who approves or funding for a drug, and his decision is informed by several perspectives. But if we look back at what CADTH recommendations are through the Common Drug Review, there's 94% agreement between our recommendation and what the public drug plans adopt, and 98% agreement on the oncology drug side. So with respect to our health technology management program, we have a number of report formats and services, and I'll tell you a little bit about each, but just really want to reiterate that part of the work that I do as liaison is to hear from you what your evidence needs are, what your decision-making needs are, and then work with you to help determine which of CADTH's products and services would be the best fit for you. So just a note about rapid assessments and traditional assessments. So part of the purpose of having a broad range of programs and services is really to support different decision-making needs, recognizing in some cases a decision needs to be made more immediately, and so a rapid review of the evidence is needed, and recognizing that there are some decisions where a more fulsome consideration of societal, ethical, clinical, economic issues is needed, and there may be more time to wait for the decision and wait for those analyses to be done before the decision is made. So our rapid response service provides rapid evidence reviews. So these reports have a relatively short turnaround time, so anywhere between 10 days and 30 days, depending on the level of detail required. So we can provide anything from a simple reference list up to a summary with critical appraisal that has been peer reviewed. So we produce over 300 rapid response reports every year, and these are just a few examples of med rehab related reports that we've conducted recently. I will share the slides afterwards so that you can access these via the hyperlinks that'll take you directly to the CADTH website. And these are just a few more. So health technology assessments, we undertake 15 to 25 health technology assessments each year. So there are thousands of new technologies, medical devices that come to market every year. CADTH can only evaluate a fraction of them. So a full health technology assessment can take upwards of 12 months to complete. And it often results in a report that is several hundred pages long. So it's very time intensive, very resource intensive to generate these. So because of this, we really try to aim to select topics that will have pan-Canadian impact. So when a request for health technology assessment is made by a province or an organization or an individual, we then undergo some scoping where we reach out to other jurisdictions across the country to determine whether or not there's a decision-making need or whether they're experiencing similar issues with the topic. And then it goes through a prioritization and scoring exercise before we move forward with conducting a full health technology assessment. And just important to note that, I did mention that we have a defined customer base who can request us to undertake work on their behalf, but anyone is welcome to submit a topic for consideration, and it will move forward with scoping and prioritization. So you can either do that through me, or there is a form on the website where you can submit that directly to CADTH as well. And these are just a few health technology assessments that we've completed recently. Now, an optimal use report is a health technology assessment that takes the additional step of making recommendations for how the health technology should be used. So we have a pan-Canadian health technology expert review committee who review and deliberate on the evidence before they issue a recommendation. And these are a few that we have looked at recently that have linkages to med rehab. We just looked at interventions for insomnia disorder, which included drugs and cognitive behavioral therapy. We looked at hip protectors in terms of falls and interventions for obstructive sleep apnea. Because many of our reports do run into the hundreds of pages, we recognize that not everyone can digest that volume of information in one sitting. So we do have a team of knowledge mobilization officers who create tools that can provide, an at-a-glance summary of what the key findings are. And this is one that was created for the Interventions for Insomnia Disorder report. That report had 3 different components. There was a clinical report that looked at the clinical effectiveness of various drugs, comparing benzodiazepine to some of the Z drugs. As well, there was a patient perspective and experience report as part of that, and a current practice analysis where we surveyed primary care providers across the country to get a better understanding of what their clinical practice and prescribing practices were in dealing with insomnia. So another piece of work that we do is environmental scanning to summarize current practice or processes that are happening at the national or even at the international level. So we'll reach out to key stakeholders with a request to complete an online survey. Sometimes we will undertake interviews with key informants and then collate the results into a final report that is made publicly available, and we do about 10 to 15 of these a year. So a couple that we have completed recently, we looked at access and availability of non-pharmacological treatments for chronic non-cancer pain in Canada. We looked at feeding and swallowing assessment services for pediatric populations in Canada. So this is a good example of sometimes if a health technology falls out of scope for a rapid response report, given that it may not have a direct patient outcome, we can look to see, have a look to see what's happening across the country or internationally with respect to different service models or programs that are available for specific populations. And then finally, we do a fair amount of horizon scanning. So we're routinely reviewing new and emerging health technologies that we think may have an impact on the Canadian healthcare system within the next 3 to 5 years. So certainly we have internal mechanisms for identifying, drugs that are coming down the pipeline, medical devices that maybe are approved and being used in the US or in Europe. But certainly, if you have health technologies that you are aware of and you believe CADTH should be monitoring and keeping an eye on, or would like some preliminary information about them, you can request that either again through me or the CADTH website, and we can have a conversation about how we move that forward. And we typically produce anywhere from 15 to 25 horizon scanning bulletins, newsletters per year. This is one that we did in the fall, which is specific focus on artificial intelligence. We've also done one recently on 3D printing. But they don't always have a specific technology focus. It may just be a general overview of new and emerging technologies in the past few months. So last but not least, I just wanted to say a few words about the team that I belong to, which is the implementation support team. Our scope covers both drugs and medical devices. There is a liaison officer in each province and territory across the country, and another part of the work I do is informal information sharing. We work closely together, so we do a lot of information sharing between provinces, so I'm always happy to reach out to my colleagues in other provinces to assess, what's happening in their jurisdiction on a particular topic, or putting you directly in touch with contacts in other provinces. So some examples of some of the implementation support services that we can provide really in order to close that gap between evidence and policy and practice, and my role being a resource to you. I'm always happy to meet and discuss how we can work together. So whether that's an initial assessment of what your information needs are or presentations on a specific topic, our team also has dedicated knowledge mobilization officers who do a lot in the way of developing plain language summaries, key messages from our reports, policy briefs, and certainly we are always happy to think outside the box and recognize that sometimes some of the pan-Canadian work that we do, it may be helpful to create tools that are contextualized to the local environment in order to help either support decision making or facilitate clinical practice change or policy change initiatives. So I think one of our most useful resources are our evidence bundles. So our knowledge mobilization officers have collated reports on important Canadian topics that are easily accessible in one place, because if you've visited the CADTH website, you'll know that we have thousands of reports available. So if you do go onto the website, you can find the evidence bundles there. We do not have one for medical rehabilitation at this time, but we do have a search function that does let you filter reports by rehabilitation. So that is available there. So I think one important note is that although all of our reports are publicly available on the website, we don't identify who made the request. So we know that there are sensitivities around decision making, so any consultation or conversations that you have with me are strictly confidential, and you would never be identified as the requester of a given report. So if you don't already, you can subscribe to CADTH updates. We routinely send out calls for stakeholder and patient feedback, as well as a monthly newsletter that summarizes new reports and upcoming events, whether that be webinars or education events that we're hosting. And then we're also active on Twitter and other social media. You can subscribe to the newsletter at the following link there, and as I mentioned, I'll share the slides so that you can access that directly. And I always welcome you to connect directly with me. I'll share my contact information at the end of the presentation, and I also have some cards if you would like that. So I'd really just like to say thank you again for the opportunity to come and talk to you and tell you a little bit more about CADTH and the work that we do, and hoping that with the remaining time we have left, we can have a conversation about what your clinical practice looks like, what your research looks like, what are the priority areas for you, and how can we work together. So with that, I'll open the floor to questions.
Thank you, Jill. At this time, we'll open the floor to questions. I would ask that you use the microphone so that people that are listening online will be able to hear the questions. Are there any questions that people have?
Hi. I'm still trying to wrap my head around exactly how to access this, who has access and everything. But my question is, so a year and a half ago, outpatient physical therapy services were cut in Winnipeg. And so when there's a policy change like that, would CADTH automatically produce some sort of evidence or report in response to the effect that that might have, or do you wait for someone to request you to do that?
That's a really good question. So all of the work that we undertake, with the exception of horizon scanning, where we're looking to identify some new and emerging technologies, the work we do comes from the healthcare system directly as a request. Mhm.
Just to tag on to that question, though, a health system change is something that you would consider doing a retro, because that's a health system change. So that, and I thought that was sort of outside of the scope of what you do.
So potentially, if someone were looking at a change in service delivery models or looking at implementing a new program model, there may be pieces of that CADTH could support with respect to patient outcomes that would be associated with that. So I am available to sit, as a committee member, an ad hoc committee member, as an evidence resource to sort of identify those opportunities where evidence review might be helpful to inform some of those health system transformations. But you are correct that in terms of us, CADTH, making recommendations about, what health system transformation should be, that's not something that's in scope for us. We're very much supporting decision making. We're not making the decisions around technologies. Mm-hmm.
Just continuing that, there was a report, one of the examples you gave was access and availability of
Non-pharmacological interventions for chronic pain
So I would
management.
just like, would that be access and availability to outpatient physical therapy services for?
Would be in scope for us because in that case, that was an environmental scan.
Right.
So it wasn't a systematic review or a health technology assessment. So we did, I have to think for that one, if we did an online survey, and there may have been some key informant interviews. So that is within scope for us to look at that, but it isn't a synthesis of the available evidence on that. It is a synthesis of what's happening across the country with respect to services being available. We've also looked at publicly funded naloxone programs in that context as well. So that gives you an example of how you might be able to take something from physiotherapy, occupational therapy, and apply it. Are we able to take questions from live stream? No, okay. So I'm just going to flip slides. If there is anyone who is tuning in via live stream who has a question for me and would like to get in touch with me, my contact information is here, so you can reach me at my Manitoba number or at jillsu@cadth.ca.
Okay. Other questions? Jill, thank you for your presentation today. Very informative. Thank you.